Hello and welcome everyone. Today we'll be doing a literature analysis of the classic RCT which was published some years back in the NEJM. In this study, they were looking at the effects of restrictive fluid therapy on the resolution of hyperlactatemia in ICU. Hyperlactatemia in sepsis is linked to higher mortality and morbidity. Traditionally, it is seen as a marker of hypoperfusion and tissue hypoxemia. Other factors increasing lactate levels are the adrenergic stress response, increased glycolysis, liver dysfunction or failure, and certain medications. Current sepsis guidelines recommend to reduce the lactate levels through resuscitation, including vasopressor usage and fluid therapy. Concerns of fluid overload complicating the management of trying to reduce this lactate is something which has been seen already. Now, study aims to examine the impact of the fluid therapy that was given on the lactate concentration. The hypothesis was a restrictive approach may not actually significantly affect the resolution time of the hyperlactatemia in the septic shock patients. The initial lactate level more than 4 indicates higher mortality in sepsis. Study hypothesizes that lactate clearance differs in patients with more severe initial derangement. Now, the methods. The study design was a secondary post hoc analysis of the classic RCT. It was registered as a clinical trial, and analysis was registered after the main trial was published. The setting was same as the classic, that is European stratified parallel group open label RCT. Investigated restrictive versus standard fluid therapy in septic shock. It was conducted across 31 ICUs in Denmark, Norway, Sweden, Switzerland, Italy, Czech Republic, UK and Belgium. It enrolled 1554 patients between November 18 to November 21. It included adult patients with septic shock onset within 12 hours and who receive at least 1 liter of IV fluids within 24 hours prior to the screening. Patients randomly assigned to restrictive or standard IV therapy for up to 90 days. The analysis subset, it included 777 out of these patients from the classic trial. The subset comprised of the Swedish, Czech and Danish patients from the capital and the Zealand regions. It excluded the 5 Danish patients who withdrew consent and 1 Czech patient who was recorded lactate concentration was not done. The ethical concerns, that is the approval, was amendment to the original classic ethical application, and various clearances were taken for this from individual universities. And the data source was retrospectively collected from the point of care blood gas analysis of lactate within the first 72 hours after randomization, death or ICU discharge. Plasma lactate measurement was not a part of the classic trial protocol, resulting in variability in the number of recorded values across patients and sites. Baseline patient characteristics collected from the classic database include age, sex, the comorbidities, the time of hospital and ICU admission to randomization, the SMS ICU and predicted 90-day mortality, the source of ICU admission, the focus of infection, the body weight, the highest lactate concentration, highest dose of norepinephrine, the volume of IV fluid in 24 hours before the randomization, and steroid usage. High creatinine concentration, use of respiratory support were also seen. In terms of the outcome, the primary outcome here was the time to resolution of the hyperlactatemia, which is defined as the first recorded plasma concentration of lactate less than 2 millimoles per liter, which has to be within 72 hours after randomization, regardless of the subsequent changes. Now, statistical analysis, the primary outcome analysis was done using competing risk regression model. Death and discharge were considered as competing outcomes. Administrative censoring imposed 72 hours after randomization if hyperlactatemia persisted, and it was adjusted for the trial site, the presence of hemolytic and metastatic malignancy, the SMS ICU score, the focus on infection, and the use of steroids, and additional analysis for patients with baseline lactate more than 4 up to 3 hours prior to the randomization was also done. The significance level was 5%. The software used was R, and the model assessment was the residual test, which indicated no violation of the proportional hazards assumption with a p-value of 0.9. The visual inspection suggested potential violations leading to time split model to allow different hazard ratios before and after day 1. Original analysis presented alongside amended analysis for transparency. The pH assumption met with the subgroups for baseline plasma lactate more than 4, so no time split was introduced. And the missing data was analyzed, included complete cases only with less than 5% of the values were missing in each analysis. So if you look at the result, 777 patients included, 129 from Sweden, 599 from Denmark, 49 from the Czech Republic. So 385 were from the restriction and 392 from the standard fluid group. The baseline characteristic generally balanced, higher prevalence of ischemic heart disease and heart failure in the standard group. So this was the classification. 154 patients, and out of this 783, and then they withdrew the consent and all those things, and then were divided into restricted or standard group. So 777 total patients. This was the baseline characteristics, and as you can see here, there was slight difference in the heart failure group. Regarding the IV fluid administration, 16,674 lactate concentration values were extracted, 8,243 for the restrictive, 8,431 for the standard. 93% in the restrictive and 91% in the standard were arterial measurements. And the outcome, no statistical difference in the cumulative probability of any competing outcomes between the groups at any point in the time. Adjusted models consistent with the primary results. A hazard ratio of less than 1 indicates lower cumulative probability of resolution of hyperlactatemia, death or discharge in the restrictive group. Subgroup analysis of the patient with baseline lactate more than 4 showed no significant difference between the groups. The adjusted models yielded similar results. Here you can see the cumulative probability that the patient is going to die based on the lactate clearance was similar, irrespective of which group the patient was in, restrictive or standard. So these are the standard deviation, this is the mean values that are going, and you can see they are essentially similar even if you look as resolution, discharge or death as your prediction. So this is the fluid volume that was different. This is day 1, day 2, day 3, cumulative score slightly more, around 1500 ml. Total volume, same 1500 ml. Cumulative balance, almost 1 liter more. So the graph that we showed, the prediction for resolution, discharge and death was similar between the two groups. There was no significant difference. Even if with the competing risk model also, we did not find any significant difference. So the primary findings was there is no statistical difference in the time to resolution of hyperlactatemia, death or discharge between the two groups in the first 72 hours after randomization. Findings align with the classic feasibility trial and strengthen the primary classic trial as well. The clinical relevance is that hyperlactatemia and delayed resolution of elevated lactate was associated with increased morbidity and mortality in sepsis. This is what I was thinking was. Elevated early lactate significantly was associated with increased mortality as per this meta-analysis by Liu. Now, serial lactate measurement is valuable in prognosis, but monitoring beyond 24 hours is not much studied. Resuscitation strategies targeting lactate clearance might lead to unnecessary interventions like fluid replacement, blood transfusions, and inotropic products. Clinicians often use the plasma lactate to guide fluid therapy, but there are few RCTs which actually look into this particular strategy of doing so. Comparative trials, there have been trials which we have discussed in our reel also on not to use lactate, the Andromeda shock trial, which led to more resuscitative intervention and organ dysfunction when you are lactate guiding, and Jones et al. RCT, which decreases the decreased lactate levels showed no significant decrease in the mortality in the lactate guided group. The Dutch trial, which targeted a reduction in the lactate levels, but then they found no significant difference any strategy you use. The ongoing Andromeda shock 2 will assess the lactate level evolution as a clinical outcome over here. Now, the strength of this particular study is that it is the RCT design because it is adapted from the original trial. The participants are from 13 ICUs with 3 different countries, so it is can be considered as generalizable. High data completeness with very low follow-up loss, that is up to 0.8% only. Achieved separation in the fluid volume, as you can see, a 1500 ml of fluid volume difference was seen. The limitations being the study cohort included only half of the original patients. The full cohort lactate procurement was not possible. Plasma lactate measurements were non-mandated, so these values were not part of the ethical consideration. Retrospective design limits the availability of the plasma lactate concentration. The blood get analysis slightly decreased as the patients improved. Now, the differences in the IV fluid volumes between the study arm were small, increasing the risk of type 2 error. And in the high baseline plasma lactate subgroup, which allowed but this actually doesn't seem to make much of a difference in terms of the outcome. So what is the take home message? The take home message is that in this retrospective analysis, a restrictive intravenous fluid therapy strategy did not seem to affect the time to resolution of the hyperlactatemia in ICU patients treated with septic shock. So a lactate guided resuscitation in septic shock may not be warranted. If you are finding the lactate is elevated, do look at other factors like tissue perfusion, heart rate, the MAP, and then guide your therapy. Don't rely on lactate as your singular target, and reduction of the lactate is associated with mortality, and I will keep on giving fluid until and unless I get a reduction in the lactate.